Hi, my name is Dan Petrylak. I'm a professor of urology and medicine at the Smilow Cancer Center at Yale University. I talked today about the controversies in renal cell carcinoma, and we divided the talk into two different sections. First was the use of adjuvant TKIs in patients who have had high-risk renal cell carcinoma after surgery. And what we concluded was the fact that these drugs have toxicity issues. There are no trials that have shown a survival benefit for either Sunitinib, Pazopanib, or Sorafenib in this particular setting. So I think that what we need are better ways to define which patients should use these drugs. Should it be high risk, although the studies have shown no benefit for the high risk patients. And I think that importantly, Sunitinib has been approved in this particular line of therapy. I think it's important that the physician have an informed discussion with the patient regarding the appropriateness of administering these drugs. The second portion of the talk was reviewing a recent study from the New England Journal of Medicine where patients were randomized to receive either Sunitinib alone or Sunitinib plus nephrectomy. And in contrast to data that Dr. Bob Flanagan presented a number of years ago, when patients with metastatic disease were treated with interferon or interferon plus nephrectomy, there was an improvement in survival for those patients who received Sunitinib alone. Now the question is whether this is applicable to all patients. The patients who had the best outcomes were those patients who were poor risk or intermediate risk. The question is whether this is applicable to those patients who are good risk, and we really don't know. The second question is, does this apply to immune therapy? We really don't have any good studies that have looked at nephrectomy prior to immune therapy for patients with metastatic disease. So I think there are some very, very important clinical questions that need to be asked based upon this data. And at this particular point, I think you need to have a discussion with the poor risk patients and the intermediate risk patients whether they should receive a nephrectomy if they're undergoing TKI therapy.